Попробуйте еще там.
Да.
Вот видео здесь горит, но видео нет по-прежнему. We try to find the video because I hear you. Oh, yeah.
Oh, yes, it's okay.
Good.
Hi, Alex.
Hi.
Good.
Hi, Alex.
To be here, to be part of our discussion.
Said, do we start?
Yes, of course. Would you please start the webinar?
Okay. Good morning, good afternoon, good evening to everybody. This is the second day of the International Endometriosis webinar at the time of COVID-19. Yesterday we had the first session, was very pleased. We had a lot of the presentation, 5 presentations from all over the world. We thank Professor Saed Al-Borzi for organizing this joint meeting between the SEUD, Asian Endometriosis and Adenomyosis Association. So we are really pleased to start the second day. The second day will be composed by 3 debates. And each debate will have 2 presentations of 15 minutes, followed by 10 minutes discussion. So now we will start from a very big issue, big discussion on endometrioma. But before to start, I wish to invite Professor Carmona to introduce himself as a co-chairman of the session.
Thank you, Felice.
Carmona.
Thank you, Felice, and thank you, Said, for giving me the opportunity to participate and to moderate this session in the second day of this amazing webinar. Yesterday, the level of the conferences was superb, and I hope that today the other speakers and myself will arrive to the same point that yesterday. As Professor Pataglia told before, I will be participating in the first debate about endometrioma. I am Paco Carmona, Francisco Paco Carmona from Barcelona, in the chairman of the gynecology department of the hospital clinic and professor of the University of Barcelona. I'm glad to be here and to share this time with you, with all of you.
I think, Paco, you will debate with Pietro Santulli from Paris. One will be in favor of the surgery, like you, and Pietro will be in favor of assisted reproductive technology. So we can start. You have a 15 minutes presentation. Go ahead, and then we do the debate.
Thank you. I'm sharing my screen. I don't know if you see my screen or not.
Yes.
Okay, let me. No, sorry.
Мы не показываем. Почему мы не показываем?
Okay. You know that it's difficult, Felice, to be totally in favor or totally against surgery.
Exactly.
In this topic. As in soccer, as in football, which better? Is better the Barça or is better the Madrid? For sure, the better will be the Spanish team. You know that endometriosis is a chronic disease, is a estrogen-dependent disease that it causes an inflammatory reaction, and endometriosis has 2 main symptoms: pain and infertility. And it's difficult to separate those symptoms and thinking only in one of them. But I will try to focus on the infertility and the relationship between one of the forms of the endometriosis, the endometrioma, and the infertility. Let me start my chrono just to be sure that I will be on time. The mechanisms of infertility in endometriosis are different. There are several mechanisms that are related with infertility, related with the pelvic cavity, related with the uterus, and also related with the ovary. And we know that the surgery is better than medical treatment for treating the infertility in endometriosis patients. The medical treatment has no place in the treatment of infertility in our patients, in our endometriosis patients. But if we operate the endometrioma, we know from years ago that the spontaneous pregnancy rate after the surgery of endometrioma is around 50% after 1 or 2 years, and it is important. During the last years, we have had a lot of new papers coming around about endometriosis. During the last 20 years, the number of papers published has been multiplied by several times, and we know nowadays that although some people, my colleague here, Pietro, and his team, they suggest that the endometriosis-related infertility is not associated with endometrioma, that endometrioma is not causing infertility in endometriosis patients per itself, because they found that the rate of endometrioma was the same in patients with and without infertility, with endometriosis patients with and without infertility. And when they make a multiple logistic regression model, they found that endometrioma was not associated with infertility. However, we know that there are several deleterious effects of the endometrioma on the ovarian function and the fertility. The endometrioma fluid is highly deleterious, and the healthy ovarian tissue around the endometrioma is negatively affected by the endometrioma. And we know that the follicular density of the healthy ovary is much bigger than the area of the ovary that is near the endometrioma. For sure, also the fibrosis is more important in the area of the ovary around the endometrioma. And we know also that the defect of the surgery is deleterious for the ovary when the surgery is deleterious for the ovary when we treat the endometrioma. This is an old study coming from the Italian group that showed that the ovarian volume after a surgery for endometrioma was lower than was the healthy ovary when you operate the endometrioma. But when you operate another kind of cyst, like a dermoid cyst, then the volume has no variations after the surgery. The same was shown with its other study by also an Italian group, in which also they found that the operated ovary has no ovulation after the surgery when the type of disease was an endometrioma. And this kind of effect can be so serious. The ovarian damage after the surgery can be so serious, even giving the patients to complete ovarian failure, that you can see in more than around 2.5% of the patients. And that deleterious effect is present even if the surgeon is a very experienced surgeon. Even in the best hands, every time you touch the ovary, you are provoking some harm to the ovary. More recently, we know this kind of this effect of the surgery from years, but more recently we have had the opportunity to study the ovarian function using the anti-Müllerian hormone, and we have also the demonstration that the surgery of the endometrioma may decrease the ovarian secretion of anti-Müllerian hormone. It is a meta-analysis, a systematic review coming from Migliana, from the Milano group, and also another this meta-analysis coming from Francesca Raffi, showing that the postoperative level of anti-Müllerian hormone is much lower than the preoperative one, showing again that the surgery of the endometrioma make a deleterious effect on the ovary. And the organizer of this webinar, Dr. Professor Alborsi from Iran, from Shiraz, showed some years ago that this postoperative decrease on the anti-Müllerian hormone was related with the age of the patient, with the bilaterality of the cyst, and with the size of the cyst. So you have a bilateral cyst in a not young woman, and you have a big cyst, maybe then the risk of provoking a more harm on the ovaries the possibility is bigger. And we know that this kind of effect is probably secondary to the you are removing of the healthy ovarian tissue when you are performing a stripping, like in this short video. The rate of having small follicles in the excised tissue is more than 50% when you're operating endometrioma, and just around 5%, 10 times less when you're operating of other kind of cysts. So even I am the speaker who is in favor of surgery. In that case, we need to be honest. We must be honest, and we must say that endometrioma is not synonym of surgery in any case. Mainly if you are speaking about fertility, if you are speaking about ovarian function. But also as a consequence of the new knowledge that we achieved during the last years about the endometriosis and about the best treatment of endometriosis, we need to know that nowadays we have to focus on the patient, not on the disease. We need to be symptom and problem oriented and not lesion oriented, and also we need to take care and to pay attention to the patient's necessities, what the patient is asking us, what the patient is demanding us, and we need to balance all the beneficial effect of the surgery on the fertility and on other different aspects, like the risk of pelvic success. We know that it is low, but it is still present when you are doing an IVF in cases of endometrioma. The risk of the rupture of endometrioma, the risk are also lower, but possible that anoculum malignancy, you may find some difficulties when retrieving the oocytes. You need to balance all these beneficial effects against all the not beneficial effects that they told you before, like the surgical related complications, including this damage to the ovarian reserve, the others, the economical cost, the pregnancy rates that are quite good with the IVF, and you need to be cautious and balance both risks and benefits of both techniques. If the patient is young, if the patient has pain, if the ovarian reserve is normal, if the male function is the male factor is absent, if you have no previous surgery, you have malignancy suspicion, maybe you have to go to the surgery and not to the IVF. And if you decide to go to the surgery, nowadays the general consensus is that the best option is the stripping, and this assumption came from all meta-analysis that shown that the rate of recurrence and the pregnancy rate was highest when you perform a stripping. However, this meta-analysis has several methodological limitations. The kind of the methods the authors used for ablating the endometrioma, the inclusion criteria, there were differences. And now I think that we need more studies to be sure about this kind of surgery is the best for endometrioma. Some years ago, we published this paper. This study is a study with longest follow-up after the treatment, the vaporization with using CO2 laser for the treatment of ovarian endometrioma. We use CO2 laser because the depth of penetration of the laser into the ovary is very small, is very few, just 0.5 millimeter, and then you can excise completely the endometrial epithelium, the topical endometrial epithelium, respecting the ovarian parenchyma. Then don't making damage to the ovary. In this study, we included 90 patients, and we randomized it to stripping or to laser ablation. That the clinical characteristics of the patients were not, they have no differences. And then the most important thing, the recurrence rate at 5 years of follow-up was exactly the same in both groups. And the pregnancy rate was also exactly the same. This is the technique that we are using now for the ovarian endometrioma treatment with laser. We are using fiber laser with this is a bilateral case. We are, first of all, we need to free the ovary to expose the inner surface of both ovaries, and then we need to make a complete ablation. Using the fiber is quite easy. There are more authors that are reporting the similar results that we have reported also. This is a paper coming from Candiani from Milano that the anti-malignant hormone was the same after the vaporization, and another paper from the same group showing that the rate of recurrence was also the same. Also, there were the randomized studies showing that the rate of recurrences and the rate of the loss of the ovarian function was the same in both groups. And this is also in this group, you can see that the recurrence was exactly the same in both groups. We have not information about dependency rate in this study, but other authors are using another kind of energy, but using the same principle, just to ablate the endometrioma, not touching the ovary. This is here you have the results from the group from Bayoras Roman, showing that the pregnancy rates are exactly the same that when the cystectomy is performed. So to conclude, maybe you have to balance both kind of options, IVF or ART techniques, human reproduction techniques, or a surgery. If you are doing surgery, then The laser vaporization is a very promising technique. We are using it systematically in cases of ovarian endometrioma because you have less healthy ovarian tissue and you are provoking less post-operative inflammation. And you have to balance it is the same slide that they showed you before that, including that you have laser or plasma or any other kind of energy that is able to vaporize only the inner surface of the body, don't touching the penetration is not so big that may harm also the healthy ovary. Is better you have always to take in mind the place of the surgery. Thank you very much. I think I finished on time, Felice.
Yes. Only 1 minute.
Okay.
Very good. Congratulations.
Thank you.
And now we move to Pietro Santulli. He's working at Department of Obstetrics and Gynecology and Reproductive Medicine. Pietro, at the Cochin University Hospital, the Faculté de Médecine de Paris. Pietro is a very promising scientist in endometriosis, one of the best young associate professor in our discipline. So we look forward to hear why he's in favor of assisted reproductive technology in presence of endometrioma. Pietro, go ahead. 15 minutes.
Dear Professor Petraglia, dear Chairman, thank you very much for this kind introduction. And I would thank the scientific committee, especially Professor Borzi, for giving me the honor to take part in this beautiful webinar. Even if we are actually in this difficult period of pandemic. And I would also gently thank the chief of department in Paris, Professor Charles Chaperon, for many daily fantastic discussion on the management of endometriosis. I have nothing interesting to disclose, and this is a very exciting debate. Who will win, surgery or RT? I would suggest probably both. I completely agree with all the concept from Professor Carmona, and this is also a very difficult debate because there are not so many randomized control trial available. But I would try to persuade you that RT is a good option. I mean, the panoramics, the French wizard, is a good option over the Spanish matador. And we should consider endometrioma as a tip of an iceberg, and its management needs to take into account some important factor. That sure, after surgery, you have 30 to 50% of pregnancy rate, but after surgery, this is the problem, is that there are problems after surgery. And when we think about problems because surgical complications, some bias in pregnancy rate, the problem of endometrioma recurrence up to 30%, the problem of alteration of the ovarian reserve, the association between endometrioma in 30 to 50% of the case, deep lesion and association of adenomyosis. So we will look some point about RT modality, then adenomyosis, then the big controversial point of surgery before RT. This figure depicts the result from the SAT registry in the United States, and we can see live birth rate after IVF, and we see that the result of IVF in case of endometriosis are higher than the global mean of all the other indications. Would clearly mean that IVF is a good option for women with endometriosis given satisfactory live birth rate as compared to the other indication. And we analyze our experience in terms of assisted reproductive technology outcome according to the phenotype, superficial endometriosis, endometrioma, and deep endometriosis. And we can see that the results are identical between among the three groups. That means that even in case of ovarian endometrioma or deep endometriosis, we have good results. And we believe that this result can be optimized using what we call a free zone approach in case of endometriosis. We published a couple of years ago a paper showing that when we make a freeze-all approach and we transfer the embryo 6 to 8 weeks after the egg retrieval, we can enhance the chances to have an ongoing pregnancy and a live birth. An important point to take into account is the association between adenomyosis and endometriosis. And in case of ovarian endometrioma, we have 30% of the cases diffuse adenomyosis associated, and in 20% of the cases focal adenomyosis associated to the endometrioma. And in case of adenomyosis, the result of RT are altered with significantly lower live birth rate and significantly higher miscarriage. So the existence of adenomyosis should be taken into account. And then let's move to a very important, crucial question of should we perform surgery before RT? I mean, which is the benefit we expect of surgery before RT? Is because to want to enhance its pregnancy rate, or because of to avoid pain or disease progression, or to avoid infection, or only because I IVF failure, or because of a large endometrioma? And if we look at the surgery, as was very well stated by Professor Carmona, if we make surgery, this literature review published last year in Human Reproduction Update show almost 30% decrease of AMH level after surgery for unilateral cystectomy, and almost 60% decrease after bilateral cystectomy. And one of the questions is the endometrioma, is there an impact of endometrioma per se on the ovarian reserve before the surgery, I mean? And to answer to this difficult question, we should try to separate the quantity and the quality of the ovarian reserve. And this is the study that Professor Carmona showed some slides in his presentation. And we published a study, and in our experience, ovarian endometrioma per se is not associated with presentation or infertility, who indirectly plead for the absence of a major impact on the quality of the ovarian reserve. And this study came from Italy, from Genova. They show that women with unilateral ovarian endometrioma, the presence of the ovarian endometrioma do not influence the rate of spontaneous ovulation. But one of the main message of this study is that they follow up, they lost from follow-up more than 30% of women, 33% of women, because of spontaneous conception during 6-month follow-up. That means that women with unilateral endometrioma and 75% of associated deep endometriosis can be pregnant spontaneously in 33% of the cases in 6 months, which is globally a very, very good result, pleading again for the absence of a major impact on quality. And this study from United States, banking on a lot of almost 4,000 PGS study on embryo to look embryo aneuploid, and they compare the aneuploid rate in women with and without endometriosis, and they failed to find any difference, who clearly mean that oocyte from women with endometriosis have no major problem of quality. Then let's move to the quantity. The quantity is a completely different story, and we found in a large study of our team some years ago that the ovarian reserve using AMH level was similar according to women without endometriosis, superficial endometrioma, and deep endometriosis. And the women with the lowest AMH level were women with a previous history of surgery for endometrioma. Again, the same message. if you make surgery, you can alter the ovarian reserve with significantly lower AMH level. And we published a couple of years ago a study of the ovarian responsiveness during controlled ovarian stimulation in women undergoing IVF with an ovarian, at least one ovarian endometrioma. And we found almost 2.5 higher risk of poor ovarian response among women with a previous history of surgery with endometrioma. Clearly, women who had been operated before for ovarian endometrioma have a higher risk of poor ovarian response, which clearly mean lower chances to have a baby. And probably 15 years ago, Garzia Velasco from the EV group clearly showed that in this seminal study that endometrioma resection before IVF is not associated to higher pregnancy rate. That clearly means that endometrioma resection before IVF is not necessary, and this is almost 20 years ago and is always the same story. And we are actually submitted an interesting study on women who had never been operated before of endometriosis, and this is a small series of women with the most severe endometriosis. I mean, women with bowel endometriosis, and in 70% of the cases, associated endometrioma, and in 90% of the cases, associated adenomyosis. And we observe, using an optimistic Kaplan-Meier method, 100% of probability of live birth rate after 4 IVF cycle, which is probably too optimistic. But if we look at the real data, we have 65% of women who had a baby after 4 IVF cycle, which is globally very good result for women with such severe endometriosis. And what about the fear of pain progression? In this controlled study, we evaluate pain progression during IVF in women with endometriosis, blue line, as compared to disease-free women, and using an oral contraceptive use before to start the IVF, we can significantly reduce the painful symptom. And during the ovarian stimulation, there is no evidence of a pain rebound during the stimulation. So globally, the data are satisfactory. And we should also observe that we compare the result of lesion, deep lesion, and endometrioma lesion before the pregnancy and after the pregnancy. And we published last year a very interesting data showing a drastic decrease of mean endometrioma size before pregnancy and after pregnancy, but also for the overall deep endometriotic lesion size. Clearly mean that if we look the lesion before the pregnancy and after the pregnancy, in most of the cases, this is a reduction in the size. And what about the fear of infection? Globally, the risk of post-egg retrieval infection is estimated up to 0.3 in the global RT population. And if you look to the specific group of women with endometriosis, the risk is higher of 0.5, but it's globally low, not so impressive. And what about the crucial point of what to do in case of previous IRT failure? There are two series published in the literature. One series from a team in Israel, and this is from a French team. And they performed surgery after a mean previous IRT cycle of 3.7, and after surgery, 33% of the patient had a delivery, and in most of the cases, almost 90% of the cases, these were the pregnancy IVF induced. But the most important message is that if you make surgery for IVF failure, remove the endometrioma, you can see that the chance to have baby that's clearly means that if surgery will remove the endometriosis, reduce the chance to have a baby. This means that the final drug for endometriosis is reserved. And if the surgery is the only option, we should think about to consider the fertility preservation. We performed 250 cycles of fertility preservation. Compare women when fertility preservation before the surgery, we can get number of oocytes. So this is the possibility of fertility preservation before the surgery. But the oocyte retrieval, they're very difficult because of the presence of large endometrioma. The team in China showed that you can make a transvaginal aspiration, like giving without oocyte retrieval. So to conclude, we published from study that the natural history by many repetitive surgeries can be and in favor of a different management, more space to the medical treatment, long-term medical treatment is to avoid the possibility of surgery. And we believe that there is option for the treatment of endometriosis, endometrioma, and maybe deep endometrial surgery is not necessary before RT. We should avoid repetitive surgeries because of the impact of the iron reserve, and aspiration before IVF increase the chances of success. And the best indication for surgery is persistent pelvic pain, and fertility preservation can be considered when surgery is mandatory. Thank you very much for the attention.
Thank you, Pietro. And now we have 7 minutes for the discussion because there is some time we used for the presentation, but I will start the discussion. We don't have yet any question from the audience. I will start the discussion with both of you. A question for both of you. We describe in the publication about oocyte preservation, ovarian tissue preservation for those patients. But how is common in your practice in Paris and Barcelona? Because I haven't seen many publications, only citation, we have to do, but what is your practical view? How many patients you accept to froze the oocyte in your clinic? Paco.
Pietro? Okay,
Paco, yeah,
I will start.
You are the
Okay.
surgeon, so you start.
I work in a public hospital, you know, and in Spain the IVF procedure is reimbursed by the, is funded by the Social Security. So we need to, and the indications are only infertility, is not preservation. Only after a law that comes from 2014, we are allowed to, in some indications, to perform ovarian preservation, ovarian tissue preservation. And it is oncology and also indications related with iatrogenic procedures. And then we have a protocol that there are three conditions as the patients has to meet for applying for ovarian preservation, that there is a good anti-ovarian hormone. They need to have more than 1.2. They must be young, less than 37, and the surgery that we are going to perform is potentially deleterious. I mean, is bilateral endometrioma or a very big cyst, more than 8 centimeters, or a unilateral cyst that is a recurrence of a contralateral ovary already operated before. And it is around 17, 20, 22 patients per year, not more.
Ah, no more. Good.
No more. No.
Pietro, in Paris?
We are very restricted.
Sure.
In Paris, in Paris, there is a possibility to preserve the oocyte if there is a medical reason, but not only an oncological reason. Medical means benign disease or a malignant disease. It means that globally the law is open and that we can propose the fertility preservation for women with endometriosis, but in reality it's not so common, and we think that we preserve almost 100 patients each year.
Okay.
And Professor Petralia is completely right. There are globally no study available in the literature. There is only one good study from the EV team, Garcia Velasco and Ana Coba, who published a couple of months ago a paper in fertility sterility about their experience, which is really encouraging, because they show a lot of pregnancy after almost 50% of pregnancy after fertility preservation in case of endometriosis.
Yes, but in this paper, Pietro, there was a lot of patients that go to the thawing oocytes just very, very short after the preservation. Probably meaning that it was a strategy, a therapeutic strategy. I will perform the preservation, I will go to the surgery, and then will be back to my oocyte. So,
I completely agree. Because the time of storage is very short.
It's very short.
Which is mean that it's not really preservation.
No,
exactly.
Global infertility treatment. I know.
Yes,
exactly. It seems like a strategical procedure. I agree with Felice. We need more data to be sure about.
We are submitting our paper, and the problem of our paper is we have 150 women, but only 2 came back to use their oocyte, because we will perform fertility preservation and we will have an answer in 10 years.
Exactly.
We have time for another short question because time is flowing. Pietro and also Paco, we know that medical treatment is generally blocking ovulation, so it's not good for fertility. However, if you plan an assisted reproduction or surgery, you like to have a 6 months or 4 months medical treatment before to do ART or surgery? Is any rationale to do this blockade of the ovarian axis and then performing surgery or ART?
Professor Petra, this is a very difficult question, because very, very difficult, because for more than 10 years, everybody cited the Cochrane from Cellam showing that gene-rich analog before IVF, but 3 to 6 month gene-rich analog before IVF enhances the chances of pregnancy. But a recent update of the Cochrane on this topic, they don't show any benefit of gene-rich analog blockage before IVF. So,
but Cochrane is not the Bible, eh?
It's
Pietro,
not the Bible.
Cochrane is not the Bible.
I know.
Cochrane should be.
But there is a very recent paper, also in fertility, I think by Hodgson, showing that the use of generates before the just a short blockade may increase the possibilities of pregnancy, and also suggesting that the use of immunomodulators like pectosyphilin may also help in achieving pregnancy. This is a very old paper that we published some years ago about the same, but from the surgical point of view, there is no difference.
No difference.
I am totally unable to differentiate taking or not any pill.
Okay.
To make the surgery easiest.
Okay, thank you to both of you. We have now to go to the second debate, which I will share together with Professor Carmona. And I have the pleasure now to introduce Professor Said Al-Borzi, because he's the organizer of this conference webinar. He's professor at the Shiraz University Medical Science, full professor. And I congratulate with him because he will be the next president of the Asian Society of Endometriosis and Adenomyosis. So next year, 2021, Professor Al-Borzi will be the president of this young society. Professor Al-Borzi will speak about traditional laparoscopic colorectal endometriosis surgery. So 15 minutes to you, Said.
Sorry, please, if maybe you can start with Professor Popov so that we can solve our net connection.
Okay.
Okay, it's good.
Okay, Paco, if you will introduce Alexander Popov, please.
Yes. Let me. Alexander Popov is.
My talk is about the functional and clinical outcome of laparoscopic resection of colorectal deep infiltrating endometriosis. My learning aims in this species is about knowing about rectal endometriosis, the common sign and symptoms, role of imaging for detecting lesions, and management of rectal deep infiltrative endometriosis. We know that ball involvement is seen in about 25 to 30% of DIE lesions. Most common site is a rectum, following by a sigmoid, appendix, terminal ileum, and ceco. Main symptoms of ball endometriosis are dysmenorrhea, dyspareunia, dysphagia, and chronic non-cyclic pelvic pain. For diagnosis, we usually start with physical examination, then transvaginal ultrasound or transrectal ultrasound, followed by MRI, and maybe we can use other imaging techniques. For treatment of these patients, if she's asymptomatic, we can only observe her. If patient had symptoms, we can include shaving techniques, disc resection, or segmental resection for these patients. And surgical approach for these patients would be laparoscopic or laparoscopic assisted. What we mean by shaving or peeling is used when endometriotic nodule is cut without opening the intestinal lumen. When shaving is unsatisfactory, disc resection should be considered. The disc resection should be performed for patients with when the nodule is less than 3 centimeter or depth of less than 7 millimeter. Segmental resection is safe for large circumferential obstructive nodules and multifocal nodules. For cases and lesions close to anal average, several surgeons prefer disc excision or shaving because it can reduce the risk of a complication and have a more favored outcomes. This is a Calvin-Dino complications. If you have urinary retention, wall abscess, or ileus, is class 1. Class 2 is when an unexplained factors, DVT complications, and bleeding required transfusion or anastomotic leakage. And in class 3, intra-abdominal hematoma or urethral stenosis, which was drained by WJ catheter, or class 3B is intra-abdominal bleeding, asymptomatic disunion, reoperation, and intestinal obstruction syndrome. So I want to show all of you our study, which was performed in a five-year period in our center. We retrospectively include all the patients with confirmed diagnosis of GI deep endometriosis. All the medical charts were reviewed and demographic information, the preoperative diagnostic evaluations, surgical approach, intraoperative and postoperative on-hand. Dysmenorrhea, followed by common clinical symptoms included dysmenorrhea in 82.5%, dyspareunia in 52.7%, and dyschezia in 55% of patients. Rectal endometriosis was reported in 88.5% of the patients in ultrasonography and only 76 near 77% in patients with MRI. And in all patients, pathology confirmed the diagnosis in these patients. So we had a report which was published in Medicine 2018, and we compared the result of transvaginal ultrasound, laparoscopy, and histopathology. At that time, we performed both transvaginal and transrectal, and also which was performed by me, and MRI by our radiologist. As you can see, the most sensitive one is transvaginal ultrasound followed by transrectal. After that, these results, we only perform transvaginal ultrasound for patients who are married, or for virgins we perform transrectal ultrasound. And adjuvant to these two techniques, MRI sometimes may be used in our center, and evaluated many with gastrointestinal DI, we perform laparoscopy shaving or peeling in which is the most common cecal involvement in 3 patients, small intestinal involvement in 2 patients, and appendectomy in addition to other GI endometriosis operation in 64 patients or 12% of were in stage 4 with a mean lesion size of 5.3 centimeters. We had only 8 cases with mucosal involvement, 1.5%, 2 cases with malignant change in appendix, which included low-grade mucinous tumor limited to mucosa and lymph node negative, and low-grade neuroendocrine tumor with masculinized and serosal surface involvement, again lymph node negative. About our complications, we had post-operation fever in near 16%, blood transfusion in 22.5%, and about the time of the operation, it's about 2 hours in shaving or peeling, 2 hours and 6.6 in disc excision, and 3.1 in segmental resection. None of the operations converted to laparotomy. We had only 1% or in 5 patients in ileostomy, which is much lower than when we compare it into literature. And peritonitis was recorded in 2 patients or 0.4%. We had 4 major complications, which was rectovaginal fistulas. Of these 4 patients, 1 of them treated with conservative management, 1 with ileostomy, 1 RVF laparoscopic surgery, and 1 RVF laparoscopic surgery and segmental resection. It's important to mention that in our center, we performed all these colorectal surgeries by our teams, and we only had help from colorectal surgeries in very difficult patients. Most of the patients operated by me. And we had 1 bladder hernia, 1 DVT, and 1 external iliac artery injury that is positive for DI on tunica externa bilateral. We had blood transfusion in only 4.8%, and disc resection 2.3%, and segmental resection 15.8%. About the time of operation, 2 hours in rectal shaving, 2.6 hours in disc resection, and 3.1 in segmental resection. The time of hospital stay is lower in the rectal shaving compared to segmental resection. We had 4 rectovaginal fistula, all of them in segmental resection group. No, 3. It was written here. Also 3 in the segmental resection and 1 in the disc excision. We had 5 ileostomy, 2 patients with peritonitis, and 1 patient with bladder hernia. Our outcome about clinical symptoms, which remained in the patient which we follow up here, dysmenorrhea up to 11%, 5% dyspareunia, and 4.4% dysphagia. So most of the patients improving and satisfied with the operation. We had 6 recurrences we had 6 recurrences in peeling method, and 2 patients with disc operation. This means that maybe that we didn't perform the operation completely, and maybe this is just remaining cells again regrow, and so patient come back with a big nodule in the rectum. About pregnancy rate or pregnancy outcome in this patient. Among 136 patients with infertility, you remember that we have 520 patients. Among 136 patient, 32 patients had salpingectomy. At the end, we
Ну, подождите, он еще не закончил. Я не могу начинать, есть ведущий, который говорит об этом.
is your rate of urinary retention is about between 0 or 70%. Urethral lesions 0 to 2%. Anastomic leakage up to 4.8% with in the presence of stoma, and pelvic abscess were all higher than with shaving techniques and disc excision in segmental resection. Our complications are very low than other studies. We had 2 cases of peritonitis, 4 cases of RBF or rectovaginal fistula, and 1 case of bladder attonia. About 10 years ago to 8 years ago, we performed nerve sparing surgery, but then we again evaluate our patient series. Now we just perform colorectal surgery without a nerve sparing because we had a very low number of neurologic problem. When the lesion is below, very low, I mean that less than 9 centimeter, patient would have long-term constipation and bladder attonia. Constipation improved significantly 2 months after segmental resection if lesion located 10 centimeter above the anal verge. Stool thinning and bladder retention problems resolved 2 months after operative gradually. The length that was removed from bowel is not associated with post-operative symptoms, and the incidence of constipation and urinary retention are not different between segmental resection and disc resection. We found that none of the patients developed anorectal or urinary incontinence after their operation and the procedure. Interest of stoma is reported in many differences in cancer surgery. No article has suggested such interest for deep pelvic infiltrative endometriosis. Leakage rate in stoma positive is 3% and stoma negative between 12 and 21%. It is unproven whether diverting the fecal stream in itself directly prevents anastomotic dehiscence. Temporary ileostomy protection on intestinal function is the question. No obvious beneficial effect on bowel function and quality of life. Increased complications include, which means obstruction, abscess, scar, hernia, leakage, etc. And patients with ileostomy and history of previous surgery had higher incidence of segmental resection stenosis. It means that if we prevent prophylactic ileostomy, it's much better. Rectal stenosis developed in 21 to 64 days segmental resection after operation with incidence of 6.3%. And conservative ileostomy should be considered in patients with very low bowel anastomosis or positive air leak test, and no obvious beneficial effect on bowel function could be found with prophylactic ileostomy. Rectovaginal fistula may frequently occur, not frequently, but maybe occur between 5 and 16 days after surgery, and especially in those patients with with treatment of both rectal and vaginal DIE. RVF rate are up to 18% in segmental resection, 11% in disc excision, and shaving, very low number, to about 2%. We had the risk factor for RVF is, as I said, treatment of both vaginal and rectal nodules at the same time, treatment of rectal endometriosis with hysterectomy, and very low anterior segmental resection, and when we had anastomotic leakage. We had only 4 rectovaginal fistula in our study, happened in patients with rectal and vaginal nodule, and then we stopped doing this technique, and if patient really needs another operation, and if still she is symptomatic, after 6 months we operate for the vagina or rectum. There are many reports in the literature, and there's some debate here about the question about how radical should be in colorectal surgery. Some are in favor of segmental resection, and some in favor of peeling or disc excision. According, there is no difference between disc excision and segmental resection in terms of recurrence rate. It was noted in some paper in literature, but we had recurrence in 6 patients with peeling technique and 2 patients with disc excision. Professor Horace Roman reported higher incidence of recurrence in disc technique rather than segmental technique, and risk of recurrence of colorectal endometriosis was in those patients who had repeated surgery, younger age, larger size of the lesion, and higher BMI. We had 25% fertility rate in our series in 111 patients who had infertility, and but in literature there is still controversy about the impact of colorectal surgery on infertility. About symptoms improving, many reports are in the literature, and as you can see, the dysmenorrhea rate decreased from 82% to 11%, 7.5-fold decrease in dysmenorrhea rate. From 52% to 5%, 10-fold decrease in dyspareunia rate, and from 50% to 4.4%, 12-fold decrease in dyschezia rate. So many patients satisfied with these operations. And we published a 6-year experience, not just only colorectal surgeries. Still, we were not submitted our colorectal series, but this 6-year experience. Next to after me, Professor Popov wants to speak about robotic surgery. There are some advantages in robotic assisted laparoscopy: greater dexterity with more dynamic range of motion, improved ergonomics, 3D visualization, motion scaling to eliminate tremor, and surgeon control of up to 3 surgical arms. But robotic assisted surgery had some disadvantages: higher cost, longer setup time, loss of tactile feedback, larger port size, and inability to remove the surgical table once docked. But this is not the issue in newer models. In segmental resection, insertion of linear stapler anvil and also circular stapler and air test should be done by surgeon itself. About robotic assisted laparoscopic treatment of endometriosis, it did not provide benefits over laparoscopy. and subgroup of women with severe endometriosis, peritoneal endometriosis, and obesity. Robotic assisted laparoscopic treatment of endometriosis should be performed only within controlled studies. There are some review literature, we reviewed the literature, and there are some articles which was published in literature, and they cannot show any benefit from robotic assisted treatment of endometriosis. In conclusions, I want to say that although less invasive surgeries are associated with fewer complication rate, the chance of recurrence of disease should be considered. It means that if you are less invasive, you had more recurrence. In this study, with a large sample size, the preoperative and postoperative complications are much lower than other studies in this special field, with the lowest number of ileostomy. And laparoscopic resection of colorectal DI is a feasible and safe method, being associated with low complication rate and favorable outcome by expert surgeon. Thank you very much. I had a video about, if I have time, I don't know, if I had time, I can show this video.
We are very late, Saed, we are very late. You should give the word to Alexander Popov.
Sorry?
We are yes. Late, depends on you. But we should go on.
Okay, okay. We can, if I have time, in 2 or 3 minutes we can. Okay, okay.
Okay, now is the turn of Dr. Popov, Alexander Popov. He's a well-known name in the endometriosis field. He is the chair of the head of the Department of Endoscopic Surgery in the Moscow Regional Research Institute for Studies in Gynecology. And he's author of numerous scientific publications, and he is one of the editors of several journals, medical journals in Russia. Alexander, you have the turn.
Yeah, thank you very much. Are you hearing me?
Yes.
Okay. Thank you again, Dr. Abouzi, and all of speakers. It's a big pleasure to be here and continue our discussion about the place of different approaches in endometriosis treatment. Thank you, Dr. Abouzi. He covered a lot of questions about definition, prevalence, diagnostic, and surgical approaches of colorectal endometriosis. I would like to continue this talk about surgical approaches, some kind of tips and tricks of surgical treatment, and again, how we can improve the infertility result of our treatment. You know well the diagnostic algorithm of colorectal and deep endometriosis, and of course, what is more important is imaging and other investigations during our preoperative diagnostic of endometriosis, and how we can decide which kind of procedure we are going to do during lab or robotic procedure. We used to do a lot of MRI, but now we use in only few cases of deep endometriosis. I prefer to do transvaginal or transrectal ultrasound examination, and today we have a good correlation between the preoperative ultrasound examination and the the correlation between pre-op ultrasound examination and size of specimen. You see well the nodule. It's a typical nodule of endometriosis by ultrasound, and if you compare the size of nodule and the size of specimen, it's the same. This slide concludes that the role of ultrasound examination in pre-op diagnostic of endometriosis is very, very, very important. But we should decide before surgery which kind of procedure we are going to do, shaving, discoid resection, or circular resection, and for that we have to do very correct examination. We have to know about length of nodule, transversal diameter, percent of involved circumference, and of course anterior-posterior diameter, and how depth of infiltration at the muscularis level. You can see well that the role of ultrasound examination very high, and if I find this nodule 4 centimeter late and 2 centimeter deep, it's a good indication to plan circular resection of bowel. A lot of classification today published about deep infiltrating endometriosis, but unfortunately we don't have ideal classification system for DIA, because one of them focused to anatomical position of nodule, another one doesn't describe the position of nodule and focus only on infertility plan. We need a new classification, new system to estimate the nodule, and this classification should help the surgeon in the planning and execution of surgery. You know well the typical position of nodule. It's a rectal sigmoid junction and rectum and sigmoid column. It's approximately 80% of nodule are there. But don't forget about right side of abdominal cavity. And if you do the revision systematically, do believe me that you can find a lot of surprise and a lot of nodule in the right side, such appendix or some kind of nodule in the intestinum or right colon. Don't forget to do revision of this part of abdominal cavity. You know well the different surgical approaches. 20 years ago, laparoscopic was offered as the golden standard approach to treat endometriosis and deep infiltrating endometriosis. But robotic assisted surgery has gained importance in the treatment of endometriosis over the last 10 years. You know well some kind of advantages of robotic system and robotic approaches, 3D imaging, flexible and small instruments, tremor ventilation, good position for surgeon during long period of surgery. These advantages let preserve the nerve and reproductive organs during fertility exchanging endometriosis surgery. But of course, we can understand that no difference between laparoscopic and robotic assisted approaches. We have to do all steps of this kind of surgery. First, adhesiolysis and restoration of anatomy of pelvic organ, mobilization of sigmoid, and we recommend starting from the white line of told fascia to explore the left Akabayashi spacing and ovarian fossa. It should be better to do ureterolysis to prevent some damage of ureter during surgery, and cold energy, cold scissor should be recommended to prevent some damage of bowel. Keystone of colorectal endometriosis surgery is the decision which kind of procedure we are going to do. Discoid resection, shaving, or segmental resection. Dr. Arbouzier showed us the special algorithm, special criteria, how we can choose the method of treatment of colorectal endometriosis. I totally agree with these criteria, which were published in 2019 by Dr. Malzoni. And you can see that if you find the big length of nodule more than 3 centimeters and the depth of invasion more than 7 millimeters, or multiple nodule of bowel, you have to do segmental resection. But in case of small nodule less than 3 centimeters, very suspicious, superficial invasion, you can do shaving or discoid resection. There are some tips and tricks of colorectal endometriosis treatment. We know well that this kind of surgery is very, very difficult and has a lot of dangerous complications. The complications are following: rectal bleeding, anastomosis, insufficiency, rectovaginal fistulas, abscess, fecal peritonitis, and the number of these complications is approximately 10%. How we can improve post-op period? Of course, care should be taken to avoid tension on the anastomosis because the risk of the leakage increase. Don't forget about blood supply. We can save the try to save all blood supply when we mobilize the bowel. And of course, if you have to do simultaneous procedure to resection of part of bowel and vaginal fornix, maybe you can separate these two procedures, as Dr. Albuzi said before, or maybe a mental flap could be recommended to prevent some kind of complication, example, rectovaginal fistula. At the end of the procedure, if you do segmental or discoid resection, air test or diet test should be recommended, and in this case we can control the hermetism of our anastomosis or our line of suture. Maybe in the nearest future, indicaine green could be recommended as a test to save the anastomosis and quality of supply in the anastomosis. I would like to share our study, the result of our study. This is a multi-center retro and prospective control study. 168 patients were operated from 2011 to 2018, and 95 women had the infertility. You can see that we did shaving and discoid resection in 51 cases and bowel resection in 44 cases. What is important when we estimate the pregnancy rate, we didn't find any difference between two groups of patients who had conservative surgery or bowel resection. I mean, overall pregnancy rate, spontaneous pregnancy rate, and IVF pregnancy rate. But in our study, if you see the overall pregnancy rate is much higher than Albuzi groups. But what is more important, the age of the patient. And in group of older patient, older than 40 years, we didn't find the pregnancy. That is why we can do this procedure timely and try to be in this group from 30 to 36 years, not after 40, because, as I said before, we didn't find pregnancy in this group of patients. Again, about the indication for bowel resection, we can support Dr. Abrau, who described the absolute indication for bowel resection. Of course, it's a pain syndrome and specific bowel symptoms such as dyschezia, rectal bleeding, pencil-like stool. Next group is a patient who had 2 or more IVF failures and bowel nodule, multifocal lesions, big nodule more than 30 centimeters or millimeters, or bowel circumference involvement more than 40%. And of course, if the nodule lesions infiltrating the muscularis mucosa and the submucosa and mucosa. In this case, you should do bowel resection. And the last of my part of my talk is about place of robotic procedure. We compared two groups of patients who were operated laparoscopically or robotically, and we share in both two groups of patients who had nodal and mild superficial endometriosis and nodal and severe superficial endometriosis. This is very short video which confirmed how we can do robotic discoid resection with a very precise technique. Of course, you can do this procedure laparoscopically, and I think the result could be the same. But for nerve sparing surgery, for best visualization, for comfortable for surgeon, it should be better to do this procedure robotically without any kind of distortion for organs, nerve, and I will show later that the number of complications in robotic group was smaller than laparoscopic group. You can do shaving if the size of nodule is less than 30 millimeter, like this, or you can do circular resection if the size of nodule is bigger or the mucosa is involved in this pathologic process. When we compared the pregnancy, spontaneous pregnancy rate in two groups of patients, we didn't find the difference between two groups which were operated laparoscopically or robotically. But what is more important, the number of pregnancy in group of patients with nodule and mild superficial endometriosis was approximately 66%. But in group of patients with deep nodule and severe superficial endometriosis was very small, less than 15%. Pregnancy rate after IVF. This slide showed us that in both groups we have this similar percentage of pregnancy rate after IVF. But when we compare the total number of complications, you can see that in robotic group we have 2 times less complication during and after surgery. And in post-op period, we have 7 times less complication in robotic group. I think it's very important thing which confirm that the robotic approach is one of the good choice to prevent some kind of very serious complications. At the end of my talk, I would like to make again to multidisciplinary team. Of course, we can invite proctologists, urologists in our team, but I think it's a time to combine and to learn new specialty like a pelvic surgeon. Of course, it's very important to have a good friend, doctor reproductive, but it's very important to consult our patients before surgery with reproductologist, not after surgery. We have good options to treat infertility and deep endometriosis, IRT and surgery. You know well that the number of IRT centers now have been increased, but majority of these new IRT centers do not have facility to perform surgery. And maybe in the nearest future, we will lose of reproductive surgery quality and professional degradation. Don't forget, and our data confirm that approximately 60% of infertile patients could be pregnancy spontaneously after timely operation and adequate operation. It means that 2 from 3 of patients with endometriosis-associated infertility do not need IRT at all. And then I would like to conclude, of course, surgery is very still important, but of course, decision is often too subjective. But I I do believe that deep endometriosis reproductive surgery is not dying out, and we cannot draw up a necrol. Thank you very much.
Thank you, Alexander. Yes. Paco, go ahead.
Okay, thank you.
We
Thank you,
have
Alexander, and
short-
thank you. And thank you, Said. I think we have time for just a short question. We are very late. I don't know. I don't have any questions from the audience, but no. Okay. But I have some question for both of you. Mainly for you, Alexander. Do you operate all your deep endometriosis by robot, or do you have any criteria for using the robot?
It's a good question. Of course, now I don't have the good answer for your question, but we try to find the good criteria and recommend one patient to do robotic procedure, other patient to do traditional laparoscopic procedure. But now we try to use robotic more often, but instead the patient with the low BMI, because it's enough room for 4 arms of robotic machine. And maybe in case of urogenital endometriosis and a big nodule when we are going to do nerve sparing surgery, I think robotic machine is better. And the last answer is the status of surgeon, because we talk a lot about what's better for patient, but I think it's time to think about the health of surgeon, because surgeon is brilliant of this problem. And if you do 4 or 5 hours laparoscopic procedure, you know well you will kill yourself. But if you do this surgery robotically, you feel absolutely better during robotic procedure.
I think I cannot use this argument with the manager in the hospital. He thinks that the price per hour of the surgeons is very cheap, and he doesn't want to increase the price he pays.
But if you compare the price of robotic machine and how we can spend to learn excellent surgeon, do believe me that it is the same money.
Any other comment, Felice?
No, I think it was two very nice presentations, and the topic is very discussed. So unfortunately, the time is flowing, and we have another debate to say.
I think, Alexander, you are sharing your screen, and you must stop doing it.
Could you repeat, please? Paco?
You are sharing your screen. May you stop it?
Oh, okay.
Just to allow us to see each other.
Exactly. We have to start with the last debate on adenomyosis now. And we have okay. You have to close the video. Stop the video, Alexander.
I closed my computer. It's okay.
No. We want you to stay with us.
Thanks.
We have Fernando Reis now from Belo Horizonte, Minas Gerais. Where is Fernando?
I'm here. Can you hear me?
Sure.
Yes,
Medical treatment of adenomyosis. Fernando, please.
Okay, I'll start sharing my screen because now I can see the
see
another screen.
Another.
Let's try.
This is Dr. Alborzi. Okay, perfect.
Yes.
Go ahead.
Okay.
Try to solve the problem.
Great. Okay, so let's talk a little bit about the medical treatments of adenomyosis. First of all, I'd like to propose you a reflection about which type of adenomyosis are we talking about? Because we use it to say just adenomyosis as a single type of disease. But when we think about the modalities of treatment that are available today, and especially of medical treatments, we should start thinking about different types of disease. Like, as you can see here in this MRI image, on the left, you see a diffuse type of adenomyosis. And in contrast, on the right, you see a focal type of adenomyosis. This is important because in a recent proposal of ultrasound classification, Dr. Lucia Lazzari and Professor Caterina Isakotos have proposed a series of ultrasound criteria to distinguish between at least 3 types of disease. You may have diffuse adenomyosis, focal adenomyosis, or adenomyoma, and they have distinguished ultrasound features. They may behave differently, and they may have different degrees of symptoms severity. In this clinical study by the same team, they show that if the patient has diffuse outer myometrial filiary adenomyosis, the menstrual bleeding pattern is much more severe than if she has only focal outer myometrial disease. So in future research about medical treatments, we will have to consider this classification and perhaps make separate observations about the different presentations of adenomyosis and the consequences of each proposed medical therapy. And how do these therapies work? If we look at a general picture of adenomyosis therapies, and we can consider this cartoon that was made about endometriosis, but the drugs are quite the same for medical treatment, you can see that generate agonists and more recently antagonists, they act just by blocking the hypothalamic pituitary ovarian axis and reducing estrogen levels in circulation. But progestins, either isolated or in combined contraceptives, they have many other mechanisms of action. And besides blocking ovulation and reducing menstrual flow, and so reducing retrograde menstruation and reimplantation of spots in endometriosis, this may have benefit also for adenomyosis by reducing intermittent bleeding within the lesions of adenomyosis. But there are many other mechanisms of action of hormonal treatments, including, as we talk about progestins, for example, reducing estrogen receptors and modulating steroidogenic enzymes, also induce autophagy, apoptosis, reducing cell proliferation, and many other potential mechanisms that may help in treating adenomyosis. So here we have a summary of which type of medical treatments are now in current use worldwide for adenomyosis. You have non-steroidal anti-inflammatory drugs, combined contraceptives, some types of progestins, including norethindrone and the levoprogesterone releasing uterine system, Dianogest. Also, that there is danazol that is still in circulation in commerce and can be used by vaginal route. And you have, of course, generate antagonists. But if we look at the evidence, there is very scarce evidence that non-steroidal anti-inflammatory drugs help in treating the symptoms and even more the mechanisms of adenomyosis. There are no specific studies in this disease. So all the results of anti-inflammatory drugs are an extrapolation from studies dealing with dysmenorrhea, and dysmenorrhea in general from any etiology, including adenomyosis. These studies show that the anti-inflammatories are better than placebo, but they are worse than hormones in terms of efficacy. So this is not absolutely a first choice based on the best evidence for treating specifically the symptoms of adenomyosis. You may probably undertreat, and you know that non-steroidal anti-inflammatory drugs have some drawbacks, and they may have adverse effects, especially if used chronically from long-term disease. And as for combined oral contraceptives, there is insufficient evidence that they are effective in reducing symptoms in adenomyosis. There are very few research studies, especially in this population. And nortriptyline acetate was tested only in one study with no control group, so it's very weak evidence. So because of this, I will move to the types of medical treatments that effectively have been studied more in depth with this population of women with adenomyosis. And in this systematic review by Professor Cristina Benetti Pinto, she shows that the intrauterine system that releases levonorgestrel has important effects that are beneficial for treating these patients, like an improvement of hemoglobin levels, a reduction in number of bleeding days, and effectively a reduction of all types of pain that is more effective than other comparators like combined contraceptives. This is one of the observational studies made with the intrauterine levonorgestrel system. It's the longest follow-up after published so far, 3 years of follow-up, and is an observational cohort study, but you can see that all parameters of bleeding have improved markedly after 3 years of intrauterine levonorgestrel system. In this randomized control trial, the intrauterine system was compared with combined oral contraceptive. And as you can see in this table, the pain scores were much reduced with the intrauterine system. It's a marked reduction in all types of pain scores, as well as the intensity of bleeding that was markedly reduced, and the effect was to some extent greater than that observed with the comparator that was the combined oral contraceptive. And another result that was interesting to note was that the intrauterine levonorgestrel system reduced uterine blood flow after 6 months of treatment. This was assessed by Doppler scan, and you see that the resistance index, for example, increased, the pulsatility index increased, and this means in a Doppler assessment that we had less uterine blood flow. And this is an additional mechanism contributing to reduce bleeding in women with adenomyosis. In this other randomized control trial, the levonorgestrel system was compared with hysterectomy. And as you see, the hemoglobin levels improved much well after 6 months and remained stable and physiological after 1 year of treatment with both options. So this medical treatment, sparing the uterus, sparing fertility, is as effective as surgery to treat blood loss in women with adenomyosis. Of course, there are women that do not respond well to the uterine system and will end as a second option, as a second line of treatment in surgery. But I'd like to stress that since this method, the intrauterine levonorgestrel system, was introduced in gynecological practice, the number of hysterectomies performed worldwide, especially in the United States and other countries, also in Brazil, dropped very markedly. So this is a clinical treatment that can spare hysterectomy and save many uteri. Let's move to oral progestin like Dienogest. Dienogest has been compared with placebo in this small randomized control trial, but with sufficient statistical power to show in a visual analog scale, as you can see highlighted here, that the pain scores decreased importantly with Dienogest, much more than with placebo. And when you compare Dienogest with GNA rate antagonists like triptorelin, there are similar effects on symptoms in general. Dysmenorrhea reduces with both methods, dyspareunia and pelvic pain in general. And also ferritin levels improve with both methods. And of course, Dienogest has much less collateral effects, and it can be used for a longer period of time compared to GNA antagonists. The only effect that was superior when you look at triptorelin is uterine volume that reduced with the GNA antagonist, but not with the progestin. And let's have a look at danazol. it's a very old drug. It was proposed for endometriosis in the early 70s, so almost 50 years ago. And it has been left out for endometriosis because of side effects with systemic use. But when you use danazol by vaginal route, you reduce very satisfactorily the systemic effects. You have low blood levels, you have no side effects on the skin, and you have a good effect with reducing of menstrual blood loss in adenomyosis, and also a reduction of symptoms, as in this paper published by Claudia Tosse from Professor Petralia group in the JPPD. You have an important decrease in dysmenorrhea, in dyspareunia, and also in the bleeding scores, and actually some degree of reduction in uterine volume, not as intense as seen with generate agonists, but also reducing uterine volume with danazol, vaginal danazol, compared in two schemes, either cyclic or continuous. The cyclic scheme here was 3 months danazol, 3 months pulse, and this was very effective to treat symptoms of adenomyosis and also to decrease uterine volume. And let's finish with a small comment about assisted reproduction. This is a very complicated issue because we can consider that women with adenomyosis, they have reduced success rates with assisted reproduction technology. Several observational studies have documented that. And as you can see, adenomyosis has lower rates of pregnancy with IVF in many studies, compared with control groups without adenomyosis, and even compared with groups with endometriosis and no adenomyosis. This was summarized in a systematic review, in which you see at the bottom the summary that effectively in case control studies, for example, the clinical pregnancy rates with adenomyosis are lower than comparing with patients without the disease. And so is the ongoing pregnancy rates in IVF that are reduced with adenomyosis. And this has been shown in a systematic review with meta-analysis. And so the question is, do we need special IVF protocols to help these patients? And the answer is, surprisingly, the evidence is still scarce. This meta-analysis from Paolo Vercellini, published some years ago, was unable to find face-to-face studies comparing different IVF protocols for adenomyosis. The only thing they could do was to show that if you use the long protocol that's shown on the top, a long protocol with pituitary blockade by generate agonist, you have no difference between patients with or without adenomyosis. And if you use a short protocol, people with adenomyosis have worse outcomes compared with those without adenomyosis. So this is an indirect evidence, and still very scarce, that the long protocol may be better compared to the short protocol. And in this other systematic review, more recently by Tainá Rocha from Maurício Abrão group, published in Reproductive Science, they show that in collecting several observational studies, not randomized trials, not face-to-face studies, they see better outcomes with the long protocol compared to the short protocol. There are some experimental therapies. Professor Guo talked brilliantly yesterday about them and about why they are going so slowly with the development of new therapies. So we cannot expect a breakthrough in the following years, because there are a few drugs in the pipeline, and most of them use common mechanisms that have been practically exhausted in the late years. But we have some different mechanisms on the right, like valproic acid, that's anti-apoptotic, bromocriptine, also by the same criteria, and also antiplatelet drugs that have been studied in animal models, and maybe they can move to clinical trials in the future. So I finish with this summary. There are no labeled medical therapies for adenomyosis. The intrauterine levonorgestrel system is effective and is well tolerated. It's a good option. Dienogest improves pain and bleeding and is also well tolerated, and it can be used for long term. And generate agonists, they reduce uterine volume and symptoms, but they have a burden. They are expensive. They have severe side effects. Sometimes they need add-back therapy, and so are not the first option. We should try some kind of progestin before generate agonists. And we should remember that all these three options, Dienogest, levonorgestrel, and generate agonists, they are contraceptive. So they have to be stopped in some time in women desiring pregnancy. And to finish long protocol and perhaps two-stage IVF, with all freezing embryos and later transfer may be options for better outcomes in IVF with patients with endometriosis. Thank you, and I'll be open for discussion.
Later,
Thank
Fernando.
you.
Now,
Thank you, Fernando.
Thank you.
Thank you, Fernando. It was a nice presentation. It was just in time. Thank you. Thank you very much. Our next speaker, yes, going to the contrary now, to the, not the contrary, maybe the complementary. We will see. About surgical treatment is the Professor Nikolai Rokhlada from St. Petersburg, from Russia. He is a very good surgeon. And now, Nikolai, is your turn. Please go on. Remember, you have 15 minutes.
Dear colleagues, can you hear me? Good afternoon.
Bueno.
Perfectly.
We're glad.
Perfectly. Thank you.
Yes. Hello, dear Felice. Dear colleagues, we are glad to meet online despite of pandemic, so we could feel that if nothing changed. The following topic after Professor Rice's lecture is logically the surgical treatment of adenomyosis. Oops, it doesn't. Okay, it switches. When we speak about adenomyosis, we should understand that this morphological pathology is quite doubtful for surgical treatment. The thing is that radical excise the adenomyosis is almost impossible, leaving uterus on its place. So we have to realize that radical surgery for treating of all the symptoms is only hysterectomy. But the obstacles are that adenomyosis is frequent. It's about 1/4 of all women in population, that its negative influence on reproductive possibilities is clear, and is frequently diagnosed in recurrent abortions, infertility, and causes with multiple myomas, thus making myomectomy not neat and more technically difficult. And today we wouldn't mention the treatment of, so to say, sleeping, non-manifesting adenomyosis. We'll talk about clinically significant forms with totally involved and enlarged uterus. You can see this MRI image is quite typical for a big size. You can see it's up to 14, 16 weeks gestation, quite big uterus. It seems to be like sarcoma, but it's not. This is diffuse adenomyosis, like we used to see in our patients before the non-radical surgical treatment. This MRI, you can see, depicts multiple myomas with adenomyosis of posterior wall and submucous myoma in the fundus of uterus. This is the picture of diffuse adenomyosis, mostly of the anterior wall of the uterus, with multiple small myomas. All those cases that I showed you in MRI pictures needed the surgical treatment because they manifested in those women, manifested with infertility, with pain, and with menstrual bleedings. Is there a place for surgery? We have a lot of approaches, only medical therapy, like it was mentioned by the previous professor, and surgical alternatives like embolizations, intrauterine surgery, ablations, myolysis, but they are quite different from our gist to save or to restore the infertility. So just recently we published a paper devoted to quality of life of women with morphological changes in the glands in Journal of Endometriosis and Pelvic Pain Disorders, devoted to different kinds of surgery in organ restoring surgery in adenomyosis. And you can see here one of the cases. This is just the medical therapy of the adenomyosis. Wonderful result. We can have a quite widespread adenomyosis of an anterior wall. And after 6 months of Visan, we have almost total clinical restoration of the situation. But the surgical strategy depends on aims. Do we need to save the uterus and fertility? It depends on adenomyotic total size, and it depends on ART plans. Do we plan cryotransfer or stimulation? And what should we do before surgery? I absolutely agree with Professor Popov that when we are dealing with the external endometriosis, maybe ultrasound is quite enough. But if we plan the resection of adenomyotic nodule, as well as some myomectomies, I think that the MRI is the first place for a surgical plan. And very frequently we use neoadjuvant medical hormones like agonists, Visan, ulipristal, or intrauterine hormonal systems. As most patients are anemic, this is the most problem for preparation for the surgery for adenomyosis. If they are anemic, our aim to get at least 90 grams per liter or more hemoglobin, especially in big volume of adenomyotic tissues, to be excised. You can see all the techniques for multiple myomectomy or adenomyomectomy that we use, all kinds of mechanical measures to lower the blood loss during surgery. It could be the temporary tourniquets or clipping of uterine arteries or internal iliac arteries. Temporary clipping for decreasing the blood loss during the procedure. Here is the scheme of typical Asada procedure, like it was depicted by Hirosio Asada in his first publication devoted to adenomyomectomies. This is his technique called triple technique. That means that you form the uterus like during the handshake form. You can see you develop two flaps and then you cover it with another flap. What is the gist of all those techniques? The main is to get the best quality of scar. And now I'll show you our clinical case. You can see this is the adenomyotic uterus, total size about 12 to 14 weeks gestation. This was manifested with infertility, with pain, with menstrual blood loss, primary heavy menstrual blood losses with anemia. We used Visan for 3 months before surgery to increase hemoglobin. It improved the VAS pain score. And we used adenomyomectomy by rollover tech, as we call it. Then we prolonged Visan for 6 months after surgery, immediate cryotransfer, and now this patient is pregnant, 21 weeks, no pathological clinical signs. And you can see what I'm talking about, the technique rollover tech. When you excise the adenomyotic tissue in the fundus of adenomyotic uterus, you usually get the defect of the tissue. You can see it here, how to close it and to get the best result from the scar. This is the technique that we depicted in our article and we use for more than 5 years. We roll over one side of the myometrium and we close it to another. So we get 5 to 7 layers of the myometrium over their myometrial cavity. And of course, this gives a good results, and I'll show you the statistics we get. Here you can see the MRI picture 3 months post-op. So this is a normal uterine size, and this was the time when we used the cryotransfer at that moment. So the best experience in the world is in Japanese hands, in the hands of Hisao Asada, the first author of this technique for adenomyotic excision. And I must say that our colleagues from Iran published as well a good work on the treatment of Asada procedure of women with severe uterine adenomyosis using their own technique. But I must say that by 2018 in literature, there are described, I think, more than 10,000 adenomyomectomies performed in many hospitals. And the main thing is the statistics, what we get after these organ-saving surgeries. We get something about 2% of uterine ruptures. We get about 1.5% of antenatal fetal death. But the main idea that we still get living interim birth after those surgeries. And I must say that our experience didn't differ from the results of our colleagues from Iran or from Italy or from Japan. 2 years ago, we published our results in Акушерство and Gynecologia, the Russian Scopus journal, the result of more than 200 surgeries. And what are the reproductive outcomes we got? We got, you can see 35 birth cases of the number of those patients who wanted to conceive. We had spontaneous abortions before 22 weeks gestation, 8 cases that formed 20%, 35 birth cases, it's 67%. Among them, 12 were preterm birth, it's about 30%. Total successful percentage, 40 of all interested in reproduction restoration, and only 2 pregnancies were spontaneous. Because during this technique of adenomyomectomy, we usually damage the tubal ostia in intramural parts of the uterus. So we do not plan the spontaneous conceive after those surgeries. And I think that these reproductive results are rather okay because they are compared to those of our colleagues. And the interesting idea was to compare the effects on the blood loss and the pain. So we do not defeat the pain at all. I mean that for 60% of patients during 12 months of follow-up, we have the decrease in pain on VAS score. But about 15%, they again get those pain scores like it was previous before surgery in more 12 months. As for blood loss, we get improvement almost of all the patients. So this kind of surgery is concerned like of course, anti-anemic surgery, organ saving, and leaving the chance to conceive for a woman with infertility. How to prepare for the surgery? If the patient is anemic, we get all the measures, either Mirena or Ginestril or Visan or Agonis, any. If the patient is not anemic, then we usually put Mirena inside the cavity before the surgery, and frequently we leave Mirena, the intrauterine hormonal system, for 6 months after, like an option for combined oral contraceptives. And I must say that the main idea of this surgery is not only to excise more radical the uterine adenomyotic tissue, but to get the best scar quality. So that's why we usually say that contraception minimum for 6 months is needed, and better not to menstruate for 3 months. So if we administer combined oral contraceptives, then we ask to take them continuously for 3 months, not leaving the time for menstrual blood loss. And we had, when I'm talking about the quality of the scar, the main idea is to get a good scar. So we had one case of placenta percreta, and again, we saved the uterus for these women. It was a term birth, term cesarean section. And this is a picture of T-shaped uterine rupture after metroplasty for placenta percreta. And the second wonderful, my favorite slide, is ultrasound at 18 weeks gestation after myomectomy. So I must say that we are all very favorable of saving the uterus in adenomyosis, and maybe we can reduce the volume size of the uterus, but the quality of the scar is the main gist of this operation. Thank you very much.
Thank you, Nikolai. Very good presentation. Congratulations. Yeah. Now we are open for discussion. Fernando and Nikolai.
Okay.
There are any questions? Paco, you have any question?
Yes, I have a question for both of the speakers. I think it was Nikolai who mentioned the use of ulipristal in adenomyosis. There are several contradictory reports. My personal experience is quite good. We published, I think, 1 or 2 years ago in JMIC, a paper of using ulipristal in fibroids with associated adenomyosis, and were quite good for us. But there are also other reports, maybe one coming from Katerina Xaukostos, reporting an increase in the severity of adenomyosis after ulipristal. Do you have experience on that? Another second question is for Nikolai. The main experience in surgical treatment of adenomyosis came from Japan, because the legislation is quite complicated, and they need to have a specific drug tested in Japanese women for adenomyosis, and they didn't until some years ago that finally they approved the use of dienogest. Do you think that the things will change after they have the option to treat patients with dienogest, and then they will perform less surgeries?
May I answer?
Yes.
Yes.
Yes. So I think that if to speak about Japanese culture, as far as we know, they have a very huge experience of dienogest usage. It's more than, for some reports, for 5 years or 8 years. Either they used dienogest for adenomyosis, conservative treatment. I don't know. I don't have this information. We were interested mostly in surgical technique, as they provided it first for the world. You're absolutely right. I started my lecture from the words that the surgical treatment of adenomyosis is very doubtful thing. And we do not know either if we preserve this uterus, either it will be possible for the term birth, for living birth, is it will be possible for the fertility realization. We're always, after Asada procedures, we're always going along the, so to say, along some obstacles. But I think that if we have the alternative for the hysterectomy for those patients that want to conceive, at any rate, we need to find a place for this surgery.
And what about embolization or HIFU?
You see, as we have the possibility for embolization. I must say that when we count the cost effectiveness of the embolization, we understand that we shouldn't use this procedure in the surgical clinic, because the surgical technique of temporary, for example, tourniquet or clipping of the arteries has almost the same effect on the volume of blood loss. Another thing is, there is some, so to say, some tactics that says make the embolization and make the surgery after 1 month, for example. If we use this technique, we do not see any improvement in blood loss at all, because 1 month is quite enough to get for collateral blood supply for the uterus, to make the same difficulties for myomectomies or adenomyomectomies. So that's why there are only, as it's my opinion, there are only 2 options. Either not to do it, if you have enough surgical skill, for example, to make the clipping of internal iliac arteries for 20 or 40 minutes that is needed for excision of adenomyosis. Or to use the embolization right at the exact day, right prior to the surgery. So maybe 30 minutes before excision of adenomyosis. But as we used to try this technique in some patients, for us, it was much more simple to put 2 clips for uterine arteries and to excise adenomyosis.
Okay. Fernando,
Alexander?
any comments?
Not
Felice,
just about Ulipristal, because Paco asked about Ulipristal. We have no experience at all in Brazil because the drug is not available here.
Now everywhere now.
Yes.
But,
No problem.
Available.
I'd like to comment because it's Professor Gu commented about the dearth of new drugs for endometriosis and adenomyosis. And the companies who are proposing new trials, they are using old drugs or reproposing drugs. And the Ulipristal for the biochemical mechanisms of action is not the best candidate to treat adenomyosis. It may atrophy the endometrium, reduce bleeding, have some benefits, but it has many other effects that it's not the best option to bet on for the future treatment.
Absolutely.
May I ask a question to Nikolai?
Yes.
yes, I have a one.
Very short question. I know your data, but you don't recommend laparoscopic approach for adenomyosis treatment. It's your principal position, or maybe you will do laparoscopic or maybe robotic procedure in the nearest future.
Alexander, very good question. I must say that some of cases when we are treating not the uterus of 16-week size, but when we deal with, for example, 8 or 10-week enlarged uterus, we do the approach by laparoscopical way. Of course, why not? We don't have robotic surgery, you know. But we use the laparoscopic approach. But if we use for example, the classical surgery for 16 or 18 weeks uterus, then we prefer laparotomy approach because there are too many technical obstacles for good suturing. That's why, for example, it's almost impossible to make the rollover technique during laparoscopy. And it's very easy to do it, and by the way, very fast to do it by the mini laparotomy.
Sure.
While we don't have any significant differences in post-operational period. By the way, I must say, like, it's a kind of joke. In Russia, when we have pandemic, for example, in gynecological clinics in emergency surgery, there are quite many situations when all the laparoscopic surgeons are ill with COVID in many clinics. And that's why my students, my gynecological students, they use mini laparotomy approach when they need the laparoscopy, but they don't have any technical possibility to do it with someone's help.
Okay.
Felice, I have one question.
Yes, yes.
To whom?
Nikolai.
Nikolai, please.
What do you think about the laparoscopy assisted adenomyosis?
Laparoscopically assisted?
Yes.
I need some details on what stage of the surgery you mean to use the laparoscopy approach.
If you want to use the not rollover technique or tree flap, but just have a wedge from adenomyosis tissue. So
okay, I understand the question, but this will be not the laparoscopically assisted surgery. This will be just laparoscopic operation.
Sure.
We can laparoscopically excise the like we do usually in myomectomy. We do many multiple myomectomies. We take 10 nodes of myomas and we suture the myometrium. There is no difference. The difference is when we excise a big volume of the adenomyotic tissue. This is the situation when we need the best quality of the scar. Now, I know Alexander Popov, he is absolutely ready to discuss whether the scar is better in laparotomic approach or laparoscopic or robotic. I must say that robotics car of Alexander Popov is the best one.
Professor Alborzi, you are the one who has to finish the webinar, closing the webinar. We have discussed now this nice topic of adenomyosis thanks to Nicolai and Fernando, and now Professor Alborzi should close the webinar.
Thank you very much, everybody. I want to thank all the speakers in today's webinar, and maybe we can have this collaboration in the near future.
Okay.
Thank you very much.
Thank you
Thank you, Sayud. Bye-bye.
Bye-bye.
Take care.
Take care. Bye-bye. Ciao, Paco.
Bye.
Ciao, Fernando.
Ciao.
Ciao.
Arrivederci.
Ecco Pietro. È sempre lì lui, eh?
Ciao.
Bravo Pietro. Ciao.